Hello and welcome to today's CID speaker series. I'm Sarah Luttrell, the Communications and Events Manager at the Center for International Development at Harvard University. I'm excited for today's discussion on global mobility and the threat of future pandemics. The format for today's discussion is going to be about 20 to 25 minutes of a presentation, and then we'll leave about 15 minutes for Q&A. And a couple of housekeeping items. So during the question and answer session, you can submit your questions directly into the chat, or you can use the raise your hand function on Zoom and you can ask your questions directly to the speaker. Our CID student ambassador, Manoj Kumar, is going to be moderating today's Q&A session. So he'll be coordinating all of your questions. We're also, as you can see, recording today's session. And the video of this event will be available on CID's YouTube channel later this afternoon. And I will also be adding links in the chat. So to sign up for our newsletter or social media channels to hear more of events like this. This semester, the speaker series is running bi-weekly, which is different from previous semesters. And the next speaker series is going to take place on Friday, February 12th. February 12th, we'll be inviting the former CEO of the International Finance Corporation, Philippe Leheureux. And the discussion will be moderated by the Harvard Business School professor, Sean Cole. So we hope that you'll join us for that discussion on the transformation of the IFC. But without further ado, I would like to introduce today's speakers. So we have Michael Clemens and Thomas Ginn. So Michael is the Director of Migration, Displacement, and Humanitarian Policy and a Senior Fellow at the Center for Global Development, where he studies economic effects and causes of migration around the world. Thomas Ginn is a research fellow also at the Center for Global Development, where he studies migration and displacement. So thank you both very much for being here today, and over to you.
Great. Thank you so much, Sarah, for having us, for organizing this, and for everyone for joining us today. As Sarah said, I'm Thomas Ginn, and joined by Michael Clemens, who will come in later. We're both at the Center for Global Development, and we'll be talking about global mobility and the threat of pandemics, evidence from 3 centuries, our recently released working paper. All right, so we know that there are large benefits of international human mobility. So obviously the tourism that we all miss, business travel, migration, etc. But any public policy that's going to be set optimally obviously needs to consider the negative as well, and the cost to that. And the cost that we are all now very saliently aware of right now is the potential for international travel to spread an infectious pandemic disease. And that's not only true during a pandemic like we're experiencing right now, but that's true anytime that we could all be kind of patient zero of a new pandemic that we don't even realize is being spread right now. And so if you extend that logic further, then that would lead to the potential for permanent limits, or what economists would call Pigouvian taxes, on international mobility. And again, in normal times, before a pandemic, not just during a pandemic, that these limits could potentially raise welfare of mitigating the potential costs of future pandemics. And so I want to be clear here that we're not evaluating in this paper emergency travel restrictions or temporary restrictions during a pandemic when we know that a pandemic disease is circulating. There's a large public health literature that largely argues that those are not super effective, but we're going to take a step back here and say, did the extent of pre-pandemic mobility exacerbate the costs of pandemics once they hit? And so we're going to think about this analogous to potentially speed limits. So we think about a speed limit as balancing the benefits of arriving somewhere faster with the risks that pose to other people's lives. So here it's the benefits that we kind of individually gain from travel and migration, and as a society gain with the risks that we could be spreading something like a pandemic disease. And so to kind of sum up the argument that we're evaluating here, there's a well-known economist who at the beginning of COVID wrote that it's not obvious that running the risk of coronavirus outbreaks every few years is a price worth paying for multiple annual vacation trips to, say, Paris and Bangkok. Severe restrictions may well be desirable and justifiable, bringing to an end a half-century of ever-increasing individual mobility. And so again, he's referring here to a permanent reduction of international mobility to mitigate future pandemics, which is what we're studying here. And as you kind of read coverage of kind of how COVID spread, you'll see this kind of seep into coverage, this same logic in New York Times and the BBC, and kind of commentators around kind of one of the drivers of why this situation is so bad right now. And we're going to kind of evaluate that directly. And so we're going to argue that this pre-existing international travel does not increase the total number of domestic infections or the total harm that a pandemic causes by the end of the pandemic. And that's what epidemiologists call the final size that we'll use here in this presentation. And so we're going to argue that both theoretically and empirically. And so we're going to not have time to go into either one in depth in this presentation. We encourage you to check out the working paper. But to summarize here, on the theoretical side, we're going to present a model based on the standard SIR framework from epidemiology that's been around almost 100 years. And so we're going to add a module around that for migration, for international travel. And the first result of that is going to be that lower levels of travel leads to a later onset of the disease. So that if you have more travelers, it does mean that the disease, you can expect that to arrive faster to kind of your country's shores. But kind of a little bit maybe counterintuitively is that this delay is quite minimal. And so we'll show this both kind of theoretically and empirically. But then the main outcome that we're interested in here is the final size, the total number of people harmed by the pandemic. And so the first question then is, theoretically, does the onset date within your country, does that relate to the final size? And so a classic result from the standard SIR workhorse model in epidemiology is that no, the onset date is independent of the final size. And so if you put those two together and say, then, well, you can implement travel restrictions. Let's say the first known case that you have of a spreading pandemic, and you implement the most perfect travel restrictions you possibly can, then that would imply that the expected final size is independent of the prior level of travel. And so pre-pandemic mobility would not impact the future harm of pandemics. Now, maybe that's not realistic. And so then the extension to that is that if travel continues during the pandemic, what would happen? And so we also explore that and say then the effect on the final size is actually ambiguous, that it could go either way by letting people that are less likely to be infected into the country and kind of dilute the spread of the disease, could be just as likely for some countries. But either way, that the kind of extent of pre-existing global mobility is going to be small for kind of any global plausible parameters. And so given that this theoretical model can present kind of ambiguous results, we're going to then take this model to the data, and we're going to look at the pandemics, influenza pandemics from 1889, 1918, 1957, and 2009, when we can kind of gather the relevant data and that were kind of major enough to show up in the data. And so we're going to look at the onset date and the total deaths from each one of these 4 pandemics. And test the predictions of this model. And then we're going to be able to test the direct prediction where we have the best pre-pandemic mobility data from the swine flu epidemic in 2008 and 2009, and look at these questions empirically. So very briefly to summarize, at the country level, we're going to estimate that a 50% reduction in travel would delay the onset, but by only 1 to 2 weeks. So again, a 50% reduction in travel would be a draconian cut to the current levels of migration. And this would be a permanent reduction because we don't know when the next pandemic would be circulating. And that would have a delay of 1 to 2 weeks. But then we fail to find any evidence that there's a correlation between the onset date and deaths in all 4 pandemics, or that there's a correlation between travel and deaths in the swine flu pandemic. And so kind of consistent with the theoretical framework. And the implications of this would be that reducing the international mobility in order to, based on the goal of mitigating future pandemics, would have large costs, but essentially kind of no benefit in what they're intending to solve. And so the analogy here that we find more apt is that this would be more like speed limits on passenger airplanes, where you may be very worried about potential accidents and potential, there are potential risks that could happen, but implementing a speed limit on the passenger airplane would do very little in order to accomplish that goal that you're setting out to mitigate. So to put this quickly in graphical form, we start with pre-pandemic mobility, and we're going to kind of say that's going to have some kind of impact on the onset date, and then the effect on final size is somewhat questionable, of onset date on final size, and then the direct impact of mobility on final size is also going to be a question that we're gonna tackle here. So real quick on the model. So we're gonna look here at 3 potential different diseases with different reproduction rates, which is the R naught number, if you're familiar with this, or D being the doubling rate of the disease at the beginning of the pandemic. And so the black line is the most severe pandemic that's doubling the fastest, up to the teal line that's still a rapidly spreading pandemic, but moving slower. On the x-axis are the arrivals to a country in a log scale ranging from the kind of highest, which would be China in our data in 2008 at almost 500,000 people per day, all the way down to almost 0. And on the y-axis are the days until in the country that the disease would be expected to arrive. And so there's 2 different things to take away from here. The first is that these are downward sloping, but at a very kind of minimal rate. And so that countries with more arrivals are likely to see the disease arrive sooner, but it's the gain is very, very minimal. And also, when we look across the different kind of parameters of the disease, that the more severe the disease, the faster the doubling rate here, even less that kind of restrictions on travel are going to buy you, simply because it's just going to overwhelm any of those kind of cuts. So somewhat counterintuitive that the more severe the disease is, the less these kind of restrictions specifically are going to buy. Phrased a little bit differently, or put a little bit differently, now here on the x-axis is the reduction in travel by percentage. You're going to see that this is really not going to bite until you get into kind of 95% reduction in travel. And even then, these delays are fairly minimal in the grand scheme of things. And so that's going to kind of tackle the mobility impact on onset part of what we're doing. And then we're going to look at kind of these other 2 components. And so when we look at how onset date potentially affects the final size, again, if we take the standard assumption in the classic SIR model that there's a constant reproduction rate of the virus, then the standard result here is that the final size is independent of the onset date, that this is driven by domestic transmission parameters, and that the onset date is not going to determine, once the disease kind of runs its course, how many people are actually harmed. Now, if you want to relax some of those assumptions that may have kind of empirical bite that we've even seen in some cases in COVID, is that potentially the mortality and the reproduction rate could be highest at the beginning. And so the kind of having the disease at the beginning could be worse and could exacerbate diseases even kind of once everything has kind of run its course. And so overall, this is going to be a kind of empirical question on this dimension. And then finally, if we look at mobility on final size directly, the first component that we want to consider and point out is that travel is going to facilitate the spread of ideas, of technology, of workers, and everything before a pandemic. And so slowing that down would also slow down some of the most key components to preventing and treating a pandemic that's evolving. But then the kind of direct costs once a pandemic is kind of happening, let's say a pandemic, that travel continues during the pandemic and is kind of related and is constrained by how much pre-pandemic mobility was happening. So consistent with intuition, if incoming travelers were more affected, then this could imply that we have, that there would be a final size. If incoming travelers are more likely to be spreading the disease, then it could be worse for the kind of host population. But on the flip side, if they're less likely to be infected, we've got a model that shows that, well, they're actually going to kind of dilute the impact on the host country. But either way, these magnitudes are going to be small, given the massive kind of more likelihood of meeting fellow kind of citizens or kind of domestic transmission relative to the probability of catching the disease from a foreign incoming traveler. So overall, the magnitudes are small, theoretically, but the direction is ambiguous. And so we turn it over to the data, and I will turn it over to Michael.
Thank you so much. So can you see my screen now? Great. Thank you all for being here. So I'm just going to put up some real numbers from 4 different pandemics over the course of 131 years, as 130 years, as Thomas mentioned. So we're talking here about the so-called Russian flu pandemic of 1889 that began in Bukhara, what's now Uzbekistan, and then Russian Empire. The 1918 influenza pandemic, misnamed the Spanish flu, the 1957 pandemic, which began in China, known then as the Asian flu, and the 2009 influenza pandemic that began in Mexico, known commonly as swine flu, H1N1. So as I'm going to break this down into 3 sections, just exactly as Thomas did. We're going to look first at the relationship between mobility and the arrival time of the pandemic. And one way to slice this is to look over time across this huge span of history. The extent of globalization, certainly of human mobility, changed a lot. What happened to the rate of spread of these different pandemics? And here's a great way to visualize the change in globalization. This is called an isochrone map that measures the time to travel from one place in the world to another. And this one happens by chance to have been printed in exactly 1889, the year of the first pandemic we're studying. It measures the time to get from London to anywhere else. So that dark blob in the upper center shows London, and if you're on a laptop especially, the legend is probably not visible, but that pink area around London is 5 to 10 days of travel time. The bright yellow is 10 to 20 days of travel time. The dark yellow is 20 to 30 days of travel time, and you're still not getting to most of South America, Africa, China, or Oceania. A travel agency a few years ago recreated almost exactly this same map for today's world. So now that dark pink area around London is 12 hours. The light pink is 12 to 18 hours, and the yellow, which is now getting to almost the entire world, is 24 hours. So really, a 1 or 2 orders of magnitude increase in the extent of globalization of travel, measured here by speed. And if you look at indicators of volume, it's quite similar, whether you measure the number of people arriving in ports, the number of people flying by airplanes over the period of history that was possible. Over this period, however it's measured, you're looking at a 1 or 2 order of magnitude increase in the volume of movement as well. And what happened to the spread of these pandemics is to me astonishingly little. So what you're looking at here is all 4 pandemics, influenza pandemics that I mentioned, along with coronavirus in 2019, just for reference, because it's very salient to us now, although we don't study it directly because the pandemic's not over, so we don't have data on the final size, of course. But for the 4 influenza pandemics we do, the horizontal axis here is the time elapsed since the start of international spread. 0 is the moment that it left the country of origin and entered another country. And the vertical axis here is the fraction of the rest of the world's population living in a country that had been reached by the pandemic, where there had been at least one case documented by that time. And you can see really rapid spread across all of these eras. In fact, if you just look at the horizontal line at 0.5, this is the moment at which the country of the median person on Earth was reached. And then look down at the horizontal axis, that moment varies by only about 6 weeks across all of these pandemics in this explosion of globalization. And you can see, for example, the fall wave of the 1918 influenza pandemic actually spreading faster to the median person on Earth, to the country of the median person on Earth, than coronavirus did in this in this age of mass mobility. Another way to slice it is to instead of looking across time as we just did, look across space in a single pandemic. So here's data for for the 2009 swine flu pandemic. The horizontal axis here, this is country level data at a moment in time. The horizontal axis here is number of incoming trips, passengers arriving in each country, the absolute number of them, which is the relevant statistic. And the vertical axis here is the day that the swine flu pandemic arrived first in each country. And you can see that being more exposed to international travel does make the infectious agent arrive earlier. What's really remarkable to me about this graph is that if you look at the actual magnitude represented by that dark line, the linear fit through all of these countries, and you say, well, what's the relationship between the arrival and a 1 or 2 order of magnitude increase in exposure to international travel? It's about 6 weeks, and that's that's a remarkable coincidence of extremely different sources of data across many different settings and different flu strains. What about this second relationship between arrival and mortality? Well, it turns out, as Thomas mentioned, that we have quite good data on this for all 4 pandemics, and there doesn't seem to be any relationship at all. So just starting with the most recent one and going backward in time, here's the data for the swine flu pandemic, country by country mortality rate estimates on the vertical axis here, and the time of arrival on the horizontal axis. Now, is it true that countries that managed to stave off arrival experienced less mortality? No. If anything, the linear fit there, that dark line, is upward sloping here. There's a non-parametric fit is the dotted orange line, much less influenced by influential observations there, and there just doesn't seem to be any clear relationship, and certainly not a clear negative relationship between late arrival, which we know is influenced to some small measure by being isolated from international travel, and reduced mortality. Same in 1957. Here for all the countries where national level mortality rates have been estimated on the vertical axis here, and the horizontal axis is the month of arrival. No relationship there at all. Countries that managed to, through their isolation from international travel networks, managed to have the disease arrive later, did not have lower mortality. Here's 1918. The fall wave of the 1918 flu pandemic broke out probably in Brest, France, August 22nd, 1918, spread all over the world quite rapidly. Some countries managed to stave it off for quite a while, famously Australia, lesser known Mauritius way out there on the right. But there is no statistically significant relationship between a later arrival and lower mortality here. It is somewhat controversial in the historical epidemiology literature whether we should consider the fall wave a separate pandemic, perhaps even a separate infectious agent, a variant, as many of us have been thinking about in the current pandemic, or whether it should be considered a single pandemic. This is just what the graph looks like if you consider the entire 1918 incident to be a single pandemic. Again, no evidence at all that countries that managed to delay arrival until a later date experienced less mortality. Finally, in the Russian flu pandemic of 1889, we don't have national level data, but there are city level data for, I believe it's 84 cities in Western Europe and North America. Whether you look, and mortality rates have been estimated using excess mortality in weekly data in all of these cities that are actually quite high quality. For a subset of those 84 cities, we have arrival time, no relationship with mortality. For all of the 84 cities, we have the peak moment of mortality, another different indicator of the timing. Again, the timing of the peak doesn't seem to have any relationship with the height of the peak, with the magnitude of mortality. Finally, and I'll close on this. We've seen a very small empirical magnitude of the relationship between mobility and arrival time, no relationship between arrival time and mortality in any of these 4 pandemics. that alone suggests that if there were to be a relationship, a causal relationship between mobility itself and mortality, it would have to pass through a channel that doesn't make the infectious agent arrive earlier, which is hard to think of, but might exist. So for the one pandemic where it's possible to do so, because we have good, high quality pre-pandemic travel exposure data, we can just look at directly at the relationship between incoming trips per capita here on the horizontal axis in the year before the swine flu pandemic hit, and mortality on the vertical axis here. And again, no hint of a positive relationship here. If anything, it's negative. And in the paper, we explore what we learned from controlling for lots of different things that could also affect mortality, such as the strength of the healthcare system in all of these countries, urbanization and population density, income per capita. Controlling for none of those things and more can get you a positive relationship, even a positive partial relationship between exposure to international travel and mortality, as the model predicts. So I just want to close by pointing out two things that we're not saying, and Thomas already mentioned this. No matter how much we stress this, we in our conversations with people, we find people saying, well, so you're saying New Zealand should just open its borders right now, and no, we are not at all studying the relationship between. We are not at all studying the effect of emergency travel restrictions during a pandemic. This is about the extent of globalization of mobility, human mobility, travel, migration prior to the pandemic, and what effect that had once the pandemic began. And another thing is we're certainly not saying that countries should just sort of let a pandemic happen and it's going to what's going to happen is going to happen anyway. Exactly the opposite of that. That there are many interventions which are shown to have a large effect on that reproduction number are not, which Thomas pointed out in basic epidemiological theory is fully determines the final size, the total amount of suffering that people have by the end of the pandemic in each country. Masking, social distancing, contact tracing, many other things. It's just that the conditional on those things, the effect of pre-existing globalization on the amount of harm suffered in a pandemic is something for which we have no clear evidence in history. And we'd love to talk with you more about it right now. And thanks a lot for your attention.
Thanks, Thomas and Michael. So now we would invite any questions and clarification. I can see a question from Julia. So Julia, may I request you to unmute yourself and ask a question?
Yeah, sure. Thanks. Thanks for the presentation. So I was wondering, you might have mentioned, but my connection kept on going on and off. But I was wondering if the lack of correlation between arrival dates and then mortality or size, as you were referring to, can be connected with the fact that there is some learning on measurement that countries do collectively as the pandemic evolves. So countries at the beginning might not be recording deaths as well as, I don't know, further along in the pandemic. So I imagine you control for these, but I wonder if you could say something about that. Thank
you. Yes, unless you'd like to, Thomas. Julia, that's a great point. The mortality data, we use some other sources in the paper, but all of the mortality data that you just saw are calculated by excess mortality methods. So they're just what are judged relative to past trends to be abnormal deaths for whatever reason. So these are not in the data that you saw for 2009. Also the data for 1957, also the country level data for 1918, and the city level data for 1889. Those are just abnormal deaths during the period that the pandemic was hitting, and they weren't medically attributed to any source at the time. However, that concern that you just spelled out would certainly apply to data, for example, that you get right now from Our World in Data, which are extremely high quality, but those are government's assessments of deaths caused by COVID, and certainly could be affected by by the development of testing capacity, which could vary over time. So what we would want for an exercise of this kind is excess mortality.
Thank you. Colin, would you like to unmute yourself and ask a question?
Yeah, just a short question. I mean, thanks, first of all. Did you ever look at, or when you looked at the correlation between mortality rate and arrival, did you ever, what's it called, check by GDP or the national possibilities of resources?
Yes, we didn't want to. If you're really interested, in the PDF we have the regression tables. It's not what I'd call a dispositive exercise, but we try controlling with the 68 data points that we have, which is not a whole lot, for income per capita, urbanization, health expenditure per capita, and to me the most important one is an index of health system capacity that was estimated by the Institute for Health Metrics and Evaluation. What they do is precisely the thing that you'd want to do if you're thinking about the other things that might determine mortality in say an African country reached late by a pandemic, is make an assessment of the capacity of the health system overall to prevent mortality for a given condition. And this is across a basket of, I think it's 24 different conditions that are not pandemic disease. They're just things that can happen to you, such as maternal distress at childbirth. In those cases, how effective is the health system at preventing deaths? And that is very strongly related to mortality in the pandemic. But even after controlling for that and income per capita and these other things, there is still no positive relationship between pre-existing exposure to international mobility and the mortality rate. And now, on a cross-country regression with 68 data points is not ironclad proof of anything. But what we're trying to do is say, well, what can the best data that we do have on historical experience tell us about this? And absence of evidence is not the same as evidence of absence, but to me it's a useful test of what should really show up if globalization itself were putting us in danger.
Thank you. Michael, would you like to go next?
Yes, first, thank you so much for the presentation, really interesting.
Thank you.
My question is just if you could say, what do you see as the main policy implications? I imagine that it might be simply that some of these permanent restrictions we see currently should not morph into more permanent restrictions. But if you could talk to that, what policy implications?
Thomas?
Sure. Thanks a lot, Michael. Yeah, I think you summed it up correctly in that, we're like worried in terms of how much countries will kind of extrapolate from their current experience and kind of post, immigrants for a long time have been kind of labeled as potential vectors of disease, and we're afraid that kind of argument will crop up, especially in the wake of such a massive kind of global health crisis. And so what we feel like we can directly speak to with this evidence here is that that kind of justification for any kind of more restrictionist policy is not kind of justified from the data. Again, as Michael said earlier, that does not mean that there are not many other kind of public health mitigation factors that can come into play and would kind of obviously make a massive difference in the final size domestically, but just that targeting this one area would not have major implications. I guess the other thing to say is you can think about if any kind of risk that is potential from global mobility, that the gains that we get from global mobility can be partially plowed into more pandemic preparation. And so, I think one thing that we're seeing here is just the kind of, in some ways, the lack of preparedness that we had for COVID. Some of the gains that we have from mobility that could be more general and not specific to a disease, we can use some of those gains to bolster our preparedness for the next pandemic. As kind of just a broader kind of a point around what we have here. Michael, anything to add?
If we have time, just two examples to instantiate what Thomas said. You know, the technology behind the technology of inserting mRNA into human cells was developed by a Slovenian migrant to the United States, who was well, anyway, that's a long story. And then the vaccine itself developed by the children of Turkish migrants to Turkey, to Germany. So I think looking at those anecdotes, we can sense that there is something about international connectedness that could have an effect that can't be measured by these kind of by our research design, certainly. And the other thing I wanted to say about your question, Michael, about other policy interventions, you know, I looked up this morning the death rate in Thailand. So Thailand is kind of a case in point of our study. The experience of COVID in Thailand is kind of a case in point, with the giant caveat that in the influenza pandemics that we're studying, the pandemic is over, so there is a measure of final size. You know, it could still be that there's a giant outbreak in Thailand and lots of people die in Thailand. But the experience to date is that pre-pandemic, Thailand had twice as many arrivals from China every day on average as the United States did. So much more exposed to globalization in the relevant sense of being exposed to China. It actually fits our regression line well, in that the pandemic got there January 13th of last year, about a week before the United States, on January 21st, I think it was. And then the United States imposed emergency travel restrictions right at the end of January. Thailand did later in March. And today, if the United States had Thailand's COVID death rate, the total mortality in the United States would be 364 people. Not 364,000 people, but 364 people, because our per capita death rate is 1,308 times Thailand's per capita death rate. So if somebody at this moment is going to say, well, you know, it was all globalization and it was Thailand's exposure to Chinese travelers that was the real problem, I mean, relative to other policy interventions that could have protected us, and which Thailand did institute, that would be a difficult case to make. And again, this is not quite comparing apples to apples, because COVID is not over.
So we still have a time for one last question, if anybody has. No. In that case, I would pass it over to Sarah. Over to you, Sarah.
Great. Thank you both very much for the presentation and the research, with, you know, so many historical learnings and so salient for our moment right now. And we look forward to seeing more that comes out from this research, and other things you might, you know, be able to find through your models. So thank you very much. And thank you all for joining. And we hope to see you in 2 weeks on Friday, February 12th, for our next speaker series with the former CEO of the IFC, Philippe Leheureux, and that will be moderated by HBS professor Sean Cole. So we look forward to seeing you then. Thank you very much.